about funding on the health sector, especially regarding the issues of HIV and AIDS National Fighting Front. So, before we proceed on to the discussion, let's have this preface, and then I'll come back right into the discussion. The HIV epidemic remains the single most human health scourge still challenging the world for the past 30 years. While globally, the epidemic shows prospects towards a decline, the magnitude of the situation in East and Southern Africa remains worrying, with approximately 19 million people living with HIV, contributing over half of the world's HIV burden, which is 36.7 million, according to the United Nations AIDS Commission Report 2016. Despite the marked progress in reducing the new HIV infections in Uganda, particularly among children, and minimizing AIDS-related deaths, the country continues to have a high burden of the disease, as indicated by the 7.3% HIV prevalence in the 2014-2015 national survey, and high HIV infections in specific subpopulations and subregions. In Uganda, free public sector facilities remain the first choice for health care for the majority of citizens, especially in rural areas where incomes remain low. However, when essential medicines and health technologies are unavailable at these sites, services and in turn health outcomes suffer. A 2010 report from the Office of the Auditor General called attention to the unacceptable number of people dying countrywide from preventable and treatable diseases such as malaria. Drug shortages in public sector facilities are an important cause of these preventable deaths. While some patients can turn to the private sector, the resulting high out-of-pocket expenses can exacerbate financial insecurities. Uganda heavily relies on external donors to finance its HIV/AIDS national response, yet international donor economies are reducing their support every other day. Although the government is to be applauded for the recently launched Presidential Fast Track Initiative for HIV/AIDS, with limited commitment of funds towards the implementation on the initiative, may not yield the required results. Recent data indicates that contributions for HIV/AIDS interventions have mainly come from the donors, particularly the AIDS development partners like PEPFAR, Global Fund, and other donor governments. AIDS development partners provided 68% to the AIDS/HIV interventions efforts. Out of the pocket by Ugandans was 20%, 11% by the government of Uganda, and only 1% by the private sector. So, considering this concern of funding challenges and deficiencies to the Uganda health sector budget, we are going to engage in an overview of this matter and propose the necessary actions the government should adopt to solve this conundrum. This program is brought to you by the USAID Advocacy for Better Health project in partnership with NTV. Thank you, our viewers, for indeed standing with us at this particular juncture as we are having this very critical discussion. And if you want online and you want to join us directly in this discussion, we're going to open up Periscope on Facebook, and there's a question posted in there. Please just progressively build up the discussion with us, and I will be referring to some of the issues that you raised on that platform. And so thank you. Let me just join direct now my panel that is going to help indeed indulge with us in this discussion. So just subject matter again is sustainable financing for Uganda's health care needs, particularly HIV/AIDS national response programs. And on set here, I have two gallant gentlemen. In the middle, I have Mr. Jude Bijirensha, the Advocacy Officer, Path Advocacy for Better Health. Jude, you're welcome.
Thank you so much.
Yes, and on the extreme left, I have Ruben Trinomjuni, the Head of Communications and Advocacy, Uganda AIDS Commission. You're welcome.
Thank you.
And this talk show is brought to you by Advocacy for Better Health, and we're delighted indeed that you're here. And let me go straight to Jude. So what does the project concept, it's called Advocacy for Better Health. What does it mean? What is the exact mandate of ABH? And in distinction, of course, from all other HIV and AIDS campaigns and advocacy groups in Uganda. I hope it's just not one of those littered agencies that are trying to just capitalize on the plague we have.
Thank you so much, Baldwin. The Advocacy for Better Health project implemented by PATH together with other CSO partners.
What is
focus. PATH is PATH. Previously, it used to be a program for appropriate technology for health, but now we refer to it as PATH. And I was saying that the Advocacy for Better Health project is focused on ensuring that citizens' voices are listened to by the duty bearers and policy makers. And in this case, we're trying to talk about financing. We want to start from the grassroots, for instance, at the community level. Can citizens who are there feel empowered to engage with their leaders at that level and ask them to provide services? And those services, of course, come with money. Therefore, budgeting starts from the lower level and it goes up to the national level. And we also are aware that districts or even the local governments have the capacity to raise resources at that level. But how much are they putting into the response on, for instance, HIV and AIDS? You find many district budgets do not have a component for instance, handling issues of HIV and AIDS. You find there is a district focal person for HIV but who has no budget. So we are looking at empowering the citizens to be able to engage those duty bearers at that level, to start demanding that they can be able to put some money for addressing HIV/AIDS issues, but also at the national level, engaging with government stakeholders and other important stakeholders in this discussion to make sure that funding for HIV and AIDS is actually increased, especially on the domestic front, so that our budgets can actually respond to the needs of our country. Because as you heard from the preamble, that 11% is what government is putting into HIV and AIDS, and that's deplorable. If all these donors, for instance, decided to pour out, we would have a serious crisis in this country. Yeah.
Okay, so what ABH is a government agency? Is it?
No, this is civil society. It galvanizes civil society voice to make sure that they can engage government, and therefore we are part of the civil society to make sure that they champion the voices of the citizens, they engage the leaders to make sure they respond to these issues. Sometimes advocacy is needed to make sure the issues are brought to the table and people are able to understand the need and how to address those areas. Yeah.
Okay, great. And we'll come back indeed to make sure that we dig deeper into those loopholes that are in the system. And now let me go just to Ruben. Ruben, you're representing the Uganda AIDS Commission, and it has its own mandate. There's an issue of that is reported, especially on infections in the country about HIV. The annual health sector performance report for financial year 2014-2015. This is a bit prior. There are more updated statistics, but this is what I have. And it states that the reduction in new infections in young and others dropped from 100,000 in 2014 to 83,500 in 2015, and new infections have reduced among pediatric, from those are young people, young children, from 12,000 in 2013 to 3,500 in 2015. There's some glimmer of hope and positive progression in the fight against HIV. So, is that part of your effort? What does the Uganda AIDS Commission exactly do?
Okay, thank you very much. Uganda, before we go to what it does, what is the Uganda AIDS Commission? Uganda AIDS Commission is the commission established by the Act of Parliament. It was in 1992, and this act places it under the office of the President. And the mandate of the commission is to oversee, is to plan and coordinate all HIV/AIDS related activities. So our mandate actually is to guide on policy formulation, which policy should be in place, and establishing program priorities. So this should be this, that coordination. Also to take lead in national planning and monitoring, to monitor how the infection goes, how different things go on, and also spearhead advocacy for HIV/AIDS activities, and many other things, including identifying obstacles, and by the way, mobilizing resources, and interestingly, ensure that we find a drug for HIV, among other things. That is what we do. So what have we done, as you asked? We have done quite a number of things, of course. You remember in the beginning, one of the serious measures, the causes of AIDS, of course, was through sexual intercourse with an infected person. But also there was this thing of blood, and that has already been eliminated completely.
The blood transfusion.
Blood transfusion, yes. You can't now fear that. Now there was this thing of injections,
Yes.
That is not an issue now. That we have made sure that all those things are no longer an issue. The issue that is now is through sexual kind of thing. So we did that and we eliminated those. And now, as you said, the rate of children was so high born with HIV, but now it's only 3,500. And we are actually moving to zero. There are things we have achieved, but we are not satisfied. We are still moving forward to ensure, as you rightly put it, well, so many people who are infected. You remember some time back the infection was at 18%. The prevalence was 18% in the whole country, but in some parts it was 30%. That was a serious epidemic. But now at least we can talk of 7.3, and the new statistics will come in, but at least we are now at 7.3 prevalence, which is a very good thing, and we have worked to ensure that that is done. We have now 1.4 people, 1.4 million people who are living with HIV, and as you have said, 83% people, new infections, that is still high, and we are working towards it. That means 230 new infections every day. So every day 230 people get infected. And among the young people aged between 15 and 24, for ladies, the new infection is 363 young girls between 15 to 24 getting infected with HIV every week.
Oh.
And then for gentlemen of the same age, 15 to 24, young boys, for them 204 people. That makes a total of 567 young people getting HIV every week. That is high, and so those are some of the areas.
Definitely, I'm going to get back to you on where that information is and how it's generated, because the people need to understand how to collect this information, how do you get to ascertain. But before we proceed, let me just 1.5 minutes before we go on. Let me first get to Jude again, and then we will continue building up on that. So we need to understand what's the campaign about ABH, Advocacy for Better Health, indeed, involved about, just as you were saying. And of course, for me, considering the sources of UNAIDS GAP report 2016, with quite a contradiction, especially in the number of million of people living with HIV. It's 1.5, for you, you're saying it's 1.4, so you need to have a balance of that. And then adult HIV prevalence 7.1, just as you said, 83,000 new HIV infections. So, Jude, what is the battle here for ABH?
I think for us as Advocacy for Better Health, the key thing here is that recently, around last year, end of last year, the government of Uganda committed itself to the new guidelines, WHO guidelines for testing and treating, making sure that everyone who is tested and found positive is immediately enrolled onto antiretroviral therapy. So that means that if the campaign is now to make sure that there are enough resources to be able to meet that number that will come as a result of this campaign of testing and treating. Previously, we had the issue where people would first, they would wait until you are almost, starting to fall sick, your CD4 count has gone down, then they would start treating you. But now, even if you got HIV 3 months ago and they test you and they find you positive, you're expected to be enrolled on antiretroviral therapy. So that means that we will have a bigger number of people who previously were not on medication.
Let me first get it right. Yes. Who bears the cost for the treatment?
The current cost now, of course, it's government. It's free at the public facilities, and that's why you see there's a lot of energy around the testing, calling upon all men, for instance, to go for HIV tests to make sure that the issue is that when they find you that you are HIV positive and you are put on antiretroviral therapy, the likelihood of you transmitting that HIV to another person when you have been on constant medication is very low. So therefore, that's the trend that is happening, but that requires a lot of resources, and that's why Advocacy is focusing on how do we make sure that we improve our domestic funding for HIV/AIDS to make sure that resources are put into buying medication, because for many years the HIV drugs have been given a budget of around 100 billion shillings, and we're saying now with the new numbers you should be looking at increasing that budget because you can't sustain the same amount of money for dealing with a different number of patients.
Okay.
Yeah.
So actually, when I come back, Jude, Ruben, you're going to help help us to understand the funding structure for the health sector, but particularly on national programs that are fighting against HIV and AIDS. In this meantime, let me just go for a break, and when we come back, our team is going to play a video for the ambassador of the US here in Uganda, trying to make a mention of some of the problems that we have here. Then we proceed on with the discussion. Thank you.
Over the years, as we have heard already from many people this morning. Uganda was devastated by the HIV/AIDS epidemic, but the country really is now on track to reach UNAIDS Global 90-90-90 targets. 90% of people with HIV diagnosed, 90% of those diagnosed on antiretroviral therapy, and 90% of those on ART virally suppressed. Uganda has reached the first and second 90% goals among children, thanks in part to an aggressive prevention of mother-to-child transmission activities supported by the government of Uganda, in particular the Ministry of Health, and the donor community. Among women, Uganda has already met the first 90 target and is on track to achieve the second 90 target within the next year. The HIV positivity rate among exposed babies has decreased from 12% in 2010 to 3.9% in fiscal year 2016 through aggressive prevention of mother-to-child transmission activities, and we applaud Uganda for the progress in this regard. However, as we all know, much remains to be done, and that's one of the reasons we find ourselves here today. Because despite the progress we have made with women in terms of the first 90 and being close to the second 90, we still have a problem with men. Currently, only 61% of estimated HIV-positive men in Uganda have been diagnosed, and only 54% have started treatment. We encourage the government to quickly implement a targeted testing strategy under the auspices of this fast-track program that aims to increase demand for HIV testing among men and decrease the stigma of seeking HIV services. And I charge all of the men out there who are listening today to be the apostles on behalf of this message, that tell your friends, tell your family members, tell the people.
So that is the resounding call to all men here in Uganda to make sure that we get more responsible in our effort to ensure that we know our HIV status. So on Facebook, just before I get my panelists to respond to that claricon call, on Facebook we asked just first at the beginning, what do you know about the AIDS Commission? And I can see from Ochen Stephen saying that it's for educating the young generations to know the danger of AIDS in this crazy world. Then I have Bongomi Nathan Sunday saying basically sensitization, counseling and guidance to people. Then somebody gets a very controversial statement, Isaac Msingu says eating donors and government funds to satisfy the greedy stomachs of USC bosses. So that is just a response, a variety of responses. So let me first get your take, Jude, on that comment about men's irresponsiveness to actually seeking a testing a testing rigor towards their health to understand whether they have HIV or not?
Yes, thank you. I think the call for the ambassador is really timely, because we have seen that what is actually limiting this fight now is the low involvement of the men in terms of the going out for tests. Because you remember we have been saying that prevention of mother-to-child transmission was lowered, because they started a program where they were able to test every woman that goes for ANC to know that they are either positive or negative, so that at the time of birth they can be helped to produce a healthy baby. But even that, during that time, they would encourage the men and say, come with your partner to the health facility to have also a test. But the men were not going. And the women were resorting to hiring boarders to take them to the facility, and they claim their husbands. And that was limiting the finding those men who are partners to those HIV positive women was a problem. And most men prefer knowing the results from their wives. If a wife goes, she tests and she finds positive, then the man comes back home and says, oh, so what did you find out? And that's quite scary. We are saying now, let the men actually move out, also access the tests and know their status. Because when they know that, then they can be able to be helped getting the medicines, and those who are not positive to keep themselves, negative.
Okay, good. And now, Ruben, let's just get back to the financing aspect. Based on the current figures, AIDS development partners are funding 68% to the entire fight, actually, to the whole health sector, literally, and to the AIDS fight here in Uganda. And out of pocket families is 28%, rather 20%. And, okay, the 68% is to the AIDS, HIV cost, I believe. It's not to the entire health sector. So then the government of Uganda only 11% and private sector only 1%. Now, you are hearing, okay, some people are commending Uganda AIDS Commission for doing a job. Others are saying, these guys are eating our money. So, help us understand the funding structure in that regard, and is this sustainable, really?
Yes, and of course, when we talk of AIDS development partners giving 68%, it's not that they give all this to Uganda AIDS Commission. Uganda AIDS Commission is the coordinator of multi-sector response. That is coordinating with government ministries, departments and agencies, and even these NGOs and other implementing partners. So it's not that this 68% comes to this Isaac Musinguzi needs to hear this, that this does not come to Uganda AIDS Commission. And of course, even if it was coming to Uganda AIDS Commission, it is coming for a purpose, not for their stomachs.
Why are you touching your stomach? To prove the fact.
Yes, if you look at mine, really, it's not as he describes it. So, and of course, we have other out-of-pocket families, individuals meeting their expenses at the government. Government also pays. And these are some of the things we see. But for example, as he alluded to it earlier, if you go to the clinic, to any health center, and you are tested and you are positive, immediately you are put on IRT. And this is government that supplies these things in government health facilities. So yes, financing, that is that. Development partners give us that, and other people and private sector gives us. But now, we are looking for more ways of increasing funding. Because a lot needs to be done. A lot remains undone because of the financing gaps. And of course, these AIDS development partners that we are talking about, we have, as you may be aware, and as our listeners may be, our viewers may be aware, the donor funding is slowly shrinking. And so, those we need to, because these are Ugandans, we have to find ways of making sure that they remain getting the care and treatment that they have been getting. Now, we are working on the establishment of the AIDS Trust Fund, which was, we had a breakfast launch this year. And so we are working on it. We are working with its house under the Ministry of Health. But we are making sure that at least 2% of beers and soft drinks and waraji and spirits and even bottled water, 2% goes to the fund. But also, the regulations of the AIDS Trust Fund also allow that some tax revenues may be taken from other taxable things, as will be determined by the Minister of Finance from time to time. So that is also another source of financing. And of course, you can never know what the minister will look at. It will be much more. and voluntary contributions. You and I can also contribute, and grants and donations from whoever wants to donate to that fund. So that is, we are making sure that we get local solutions for some of these local challenges, and we estimate that this will generate $2.5 million, which is around 8.6 billion. And among other things, we are working on recently on the 7th of June this month, we launched what we call the $1 initiative. This $1 will require that you and I can put a minimum of $1. It doesn't have to be $1, it can be Ugandan money, but at least give us 3,600 and so for the fight. So if you give, and this is per year, that is just if you give $1 per year, but we are also saying actually you can give much more. This is an initiative that has been initiated by the private sector purely, who are our funders. So they have at least $1, and then guidelines on how it is going to be done are underway. And this money we are looking for towards generating another source of income to cater for AIDS problems. And we are also looking at private-public partnerships where the government can partner. For example, if it is building infrastructure in place, the government partners with the public so that at least services can be easier and resources can be got. Also, we are mainstreaming HIV response in public and private projects and also infrastructure. For example, if they are constructing the road, for example, some money will be put aside for HIV activities purely. You always see on the signpost.
It's part of the construction budget?
Yes, it's part of the construction budget.
Infrastructure construction budget.
Yes, and even all these ministries and agencies, we are saying put a certain percentage of money to cater for HIV activities in all ministries. All right,
just a pause on that. We're going to continue juggling. I need to, because of the time rundown. Let me just first get to Jude again. So there's a concept called health commodity security. Okay, I think basic medicine services, but I want you to help us understand that. And so what loopholes are in our healthcare system management that normally actually threaten the reliable supply and consistent availability of essential medicines in public health services? So because if there are certain loopholes in there, we usually hear that medicines actually get expired, medicine gets stolen. Of course, that's a corruption aspect. But first, help me understand the concept of health commodity security, and then give us those loopholes and how they can be shut down in a synoptic way.
Okay. Thanks so much for that. When we talk about health commodity security, we are looking at the entire health system in this country depends on certain items to be able to function. For instance, if you go to the hospitals or the health facilities, you find that the health workers who are there will need medicines to be able to prescribe the patients who come for different ailments. So that is part of the commodities. We'll talk about, for instance, gloves, for examination gloves. They will need equipment to use in the process if they are doing any
essentials.
Yes.
Okay.
So they will need all that to be able to function. Sometimes you find that they need even simple things like drip water, and then you find it is not there. Then the connection tubes and all that. So all that is what we talk about by health commodity security. So should we go to a health facility, all these things should be there to be able to function. If one of them is missing, then the quality of service is going to be very poor. And this has been the case. You hear so many times people go to the health facilities and you find maybe one or two items is missing. Our health facilities have been known to prescribing mainly Panadol, which is a simple drug for aches and pains. But then the other drugs you are told maybe you go and buy from a private health facility. And that disconnects the entire chain of treating someone. Because when you send them, you are not very sure that they will go and buy this medicine. Some of them choose to go home and sleep because they don't have the money to buy the medicine. So that means that you will find people who are constantly getting, serious illnesses because they did not achieve the prescription that they were told to get from the health facilities. And at times you'll find that in some health facilities you'll find gloves being used by more than gloves are used on more than one patient because they don't have enough. They are trying to look around to see what can be able to be used. But yet we know some of these things, government purchases them and they are taken to the health facilities, but how they are utilized and sometimes even the processes of quantification. Sometimes they may think they will handle 30 patients in a week, and then the patients are more, and therefore some of these items run out.
So any 30 seconds kind of solution or suggestion?
I think the whole point is going to be focusing on improving the quantification, but also the monitoring of the usage of these items. And that's why we are, for instance, as Advocacy for Better Health, we are empowering the communities, the local health unit management committees, and the leadership in the area to be able to take an interest to monitor what comes to their health facilities and how it is utilized, to be able to know where the gap is.
Okay, good. Let me get back to Ruben. So there's the annual, let's talk about the issues of still continuing with health essentials. Okay, the annual health sector performance report financial year 2014-15 stipulates that only 8.5% of government's health expenditure, rather of government budget, is actually expended on the health sector. So what's the current supply chain arrangement? Because the supply chain system of where you get the medicines from, or who stores them, and how they are handled matters. Just literally build up on what she's saying. What are the challenges in that entire cycle of ensuring that actually drugs are effectively utilized in that supply chain system?
Okay. Well, thank you. As I told you earlier, ours is coordination, not necessarily implementing, distributing drugs no, but normally what happens when we go to districts and in the field, people tell us that this is lacking. But of course, as a government, we know who does what, so we normally coordinate. If it's national medical stores, we call them, they supply. If it falls under the Ministry of Health, we know how, we have close contact with them. So we work
you understand the reason I'm asking is that if you can be able to maximize the capacity of this entire supply chain and make sure that you don't allow leakages and maybe the destruction, the waste of these drugs and essentials, you'll actually have, you can be able to survive without maybe donor funding.
Yeah, that's true. Normally, what we do is to ensure that there is even distribution of some of these services. For example, we monitor to ensure that donors or implementing partners are not concentrated in one place. We send them to different places where they can be more effective than being in one place. So ours is coordination, to ensure that this is here, this is there, and when there is such a thing as shortages, when we are informed, of course, we coordinate with relevant authorities and bodies to ensure that there is steady supply of what is needed.
Okay, yes. And now, Jude, in the same vein, if you can manage the health care personnel, especially the medical doctors, the health workers, it can also help improve greatly on the resources that we are yearning and crying for. Still, the same particular report, because usually the health sector usually churns out reports every year. So 2014-2015 says that 69% of approved posts were filled by health workers, implying that about 31% positions are not filled in. And then you have less than 70% reduction in absenteeism in the public health sector, and then you have the village health teams only built up to about 75% in the health sector. My statistics are a bit 2 years back, but that's the material I could get hands on. So, how do you, the problem of poorly motivated and minimally empowered health workers can actually exacerbate the whole spillage and the wastage in the system, that even if you have all the resources, or you have only these resources from our public fund, that they will be wasted. So how do you ensure that you improve this situation? And we go, your advice, you're not an implementer, I know, but
yes, thank you so much, Baldwin.
Yes.
The issue of staff, health workforce motivation is critical in terms of achieving the results we really want as a country in caring for its people. we know that there are so many issues that are affecting the health workforce morale. Sometimes some of it is to do with the equipment that we have been talking about. For instance, if you go to a health facility to work and there are no medicines, the motivation is already being affected because you don't have the tools. You are being deployed, but you have no tools for the trade, and therefore that affects motivation. So if we are going to be able to improve the health workforce, those commodities must be available. But also the other thing is also we have been talking about the issue of how do you retain health workforce, because some places are well known for being, very distant and inaccessible, sometimes hard to reach areas. And the government, good enough, has put some, hard to reach allowance for those areas. But more and more areas keep coming up saying we are also hard to reach. So how do you address those areas, make sure that the health workers who are there can actually stay there and work? And then making sure that there is accommodation for these health workers to be able to work in these areas. Because if they don't work and absenteeism keeps going up, then the quality of care is going to be affected. But also, the Parliament sometime gave a recommendation that, the health workers should be able to access a lunch allowance, that government contributes money to improve their lunch allowance. It has been something like 2,750. And 207,050 for lunch, you would be thinking of buying maybe a commando, as we call it. And that is the cheapest food that you can probably get. But we want, if it can be increased to the recommendation of Parliament of something like 12,000, then a health worker could be able to get a decent meal. Even if it is a takeaway and is still at work, he can be able to access a decent meal and carry on working and feel motivated that he's also getting something from what he's doing, or how he's serving the people, and he can feel really motivated. But also we have a large number of health workers who have, for instance, gone out for training. He has been a nurse, now he has done a diploma and upgraded. But when they come back, they are always retained at the same level where they were, in terms of their salaries, in terms of promotion. So many health workers actually remain at the level where they were, despite getting a higher qualification. So therefore, they feel that their education has been put to waste. And remember, sometimes they take off leave to do these studies. When you go to health facilities in the upcountry, you find that they will tell you we have so many health workers, but 2 of them are on study leave. But when they come back, they are not given what they expect in terms of the salaries, but also, so they start looking for better opportunities. And we have also a different cadre that has been in acting position, acting capacity for many years.
So
DHOs who have been in acting capacity, who cannot be able to make good decisions, who cannot be able to go out for supervision diligently, because when you are in acting capacity, somehow your hands are somehow tied. You don't do as someone who is substantive in a post. And I'm glad that recently the PS Minister of Health announced that the chief administrative officers should be able to fill those posts of DHOs substantively, so that they remove these people who are working as, maybe they get someone from the health sub-district to act in that capacity. So he's moving in between the health center to the district, and that affects the way services are delivered. So monitoring will be critical, and supervision and upgrading their levels of qualifications.
Okay, something is being done, but something more needs to be done. So Ruben, when I come back, I need you to help us also in the general international picture. There is a 90-90 percent promotion concept by the UNAIDS, so I need you to talk about it. And thanks to our viewers for keeping with us. When we come back, we're going to have a wrap-up phase in this discussion, and thanks for continuing with us on Facebook. I'm going to cite out just a few of your comments when I come back. Thanks after this short break.
It is said even now, who rested my worry, said, no, don't worry. They live longer, but they don't infect, which is very good. But in your interest, I know the Ugandans will do it, because the Ugandans like education. The problem is not them, it is you people. It is the ministry, it is the AIDS Commission, it is the district health sickness officers. You are the problem. The Ugandans, once you tell them, they will do it. So that's how we fought even the war in the bush. These were villagers. I would tell them that when the enemy comes, you do this. They do it. That's how we defeated the government army. The Ugandans listen. But you don't talk to them. This is the problem. So now here, before this era, these were used widely. 100,000 people were dying each year. When they were used widely, the deaths have now decreased.
So Ruben, actually the critical part of that submission by the president needed is that actually you people who are doing the HIV/AIDS advocacy, making sure that you have a fight at hand to reduce this, you're actually not doing your job. Of course, I'm glad ABH Advocacy for Better Health, you're here to make sure that you address the nation, but you're not talking to the people, and you're being accused for being in the system, making an impression that you're doing this job, but actually you're not doing so. That is his own words. So I don't know what your response is before we come to the next.
Yeah, the response.
Are you doing your job?
We are doing our job, and as of course, as I gave the statistics, if you can look at how we have reduced the rates in every sector, people living with AIDS, new infections, children, how many people have accessed ART, antiretroviral treatment. We are doing the job. But of course, as I said before, there is more to be done, and we are up to the task. And we have actually, we have put a very good strategy to do much more. It's in place, and we'll do it, and the president will appreciate our efforts because they will be very visible. But of course, even now, we have something to show that we have worked, and it's written, it's available. Yeah. So about the 90.
Yes, there is an initiative that was introduced by the UNAIDS, a global kind of guidance program, seeking that we have an ambition to make sure that we have zero new infections, zero HIV/AIDS related mortality and morbidity, and zero discrimination by year 2020. Okay? And so these efforts were adapted by Uganda. So can you have an explanation of that idea of 1990?
Yeah, the idea of 1990 is that 90% of the people who are HIV positive are identified through testing. Yes, if 90% of the people who are living with HIV/AIDS are identified through testing, that is the first 90. Then 90% of these identified people living with HIV are enrolled on ARVs.
Yes.
And then 90% of these people who are enrolled on ART,
yes,
antiretroviral treatment, their viral load is suppressed. By suppression, we mean, for example, if you are consistently taking your ARVs, chances are high that you will not infect the person. But that is not to say that since I'm taking, let me continue. No. But at least it can be suppressed, so you will not have, you can live longer and you cannot infect other people. So the 90-90-90 target is that 90% of people living with HIV who are HIV positive are identified through testing. And then when you identify them, you get 90% of those on treatment. And then as you put that 90 on treatment, at least 90 of these who are on treatment have their viral load suppressed, they are healthy, they are strong, they can go on doing their normal business. And also, chances are high that they will infect others. So the rate of infecting others is reduced. That is the 90, 90, 90. It augurs very well with the government plan of test and treat. So before, they used when they test you, then you wait until your viral load is, but now they test you immediately. When you are positive, you begin on treatment. And that has done a very good job. And of course, as the ambassador said, we have done very well on the 90s.
Okay.
We are on track.
All right. So let me just get Jude's response on this. You see, the 2014 statistics I think that was done still by the Ministry of Health. It says that West Nile has 4.9% AIDS prevalence, Mid-Northern section has 8.3%, Central Region Part 2 has 9.0% HIV prevalence, Central Region 10.6%, which includes Kampala and of course Lake Victoria, has 10.6%, and on. East Central has 5.8%, Mid-Eastern has 4.1%, and Midwestern 8.2%. Now, these are very glaring statistics. They are still in single digits, but yeah, you don't want to still hear that somebody is getting infected with this. But so how viable is this ambition to have actually HIV eradicated by 2040 with all these economic, social, and of course financial deficiencies that we're having, and the political wrong 2030 literally, and of course the corruption that goes on and the threat of the donor community actually failing or ceasing to give funding to this effort. How viable is this aspiration? Or we're going to have a reversal in this situation?
Thank you so much, Paulin. I think it is the targets are ambitious, but I think they are doable. What is required is really the political will to make sure that which is available and as espoused by His Excellency the President, and therefore cascading it down to make sure that even on the part of the population we also do our part, because what we've been actually the messages we've been putting out have been mainly that the citizens have to play their role. While government does its bit, the citizens have to play their role. For instance,
so the citizens will tell you that it's paying taxes. Yes,
they will pay the taxes, but in terms of, can you, for instance, go and get a test? Government is not going to drag you from your house with a chain to take you to a health facility for testing. It's going to be a personal responsibility to make sure that you can be able to go out and get the test. And when you find yourself, for instance, HIV positive, then swallowing off the drugs is going to be your personal responsibility, because we know that adherence sometimes affects the way people respond to treatment. If you take drugs today and you miss drugs tomorrow, I mean, government is not going to come to your house tell you how you should take your drugs. They will give you the drugs, but then the responsibility to make sure that you take the drugs is going to be yours as a person who is living with HIV, to make sure that you can make some gains and you achieve a better life. So there are two ways. There has to be the government, those who are charged with the responsibility to make sure that they take services to the people, but also the population must play their bit. Because we have been having cases where we've been hearing that some people now are no longer taking medication because of hunger, and that already affects the adherence, meaning that you cannot be able to suppress your viral load if you are not adhering very well with your drug.
Okay, yeah. And too much. Just I don't know whether any of you has a recollection. We're about to wind up.
Yes.
Do you have the figures of how much an ARV dosage, maybe for 1 month for a person, costs to the government?
It's about $300.
$300.
Yeah.
That
and that depends also on the what line you are on.
Okay, good. Now,
first line, second line, third line.
$300. I think that needs to be renegotiated. Now, Ruben, just to wrap up. I just have 1 minute. What is your winding up shot, and then we wrap up on this.
Yes. Thank you very much, Baldwins and our viewers. The responsibility of financing for HIV is our concern. and the government is doing what it can. The donors are doing very well, are supporting us. But also, as you know, the public also have been financing. Now we have launched this $1 initiative. We are calling upon the private sector, individuals, to donate that $1 initiative to support and augment other means of financing that we have been in place. We have a resource mobilization strategy that we are following. We are actually trying to make sure that there is some funding, and so we cannot succeed without you and me and everyone's contribution.
Oh, okay,
That's
thank
what
you.
we are going for. But also,
Ruben, just for pop. Okay, just 30 seconds, please.
Yes,
I don't want to sound rude, but we need to wrap up. Yes.
Thank you. No, as the Commission, responding to the President's call, we are actually now moving to the villages, the communities. For example, last Saturday we went to secondary schools. We are championing debates in partnership with National Debating Council. We are at PMM Girls School in Jinja. Next week we shall be in Bweranyanji. We are going to the real people to make sure that we reach them, they get the information, and they respond. Okay. And by 2030, we shall reduce age.
All right. Hopefully, if we are all living, you'll be back here and we'll be grueling you to understand the program. So, Ruben Trinomjuni, the head of Communications and Advocacy, Uganda AIDS Commission, and Jude the Jirensha, the Advocacy Officer, Path Advocacy for Better Health. Gentlemen, it's been a pleasure indeed hosting you, and thanks for your work. God bless indeed. And thanks to our viewers. Apologies, I could not cite on social media action, but please continue having the discussion there, just because of time. And if you're out there, you are an NGO, you're a government parastatal agency, or a corporate company, and you want to have a very organized and detailed discussion about any message you want to pass on to the public, please come talk to our MD here, or our sales and marketing team, and let's find a way on how to make sure that this happens and you have your message passed out. And thanks to my producer, thanks to our marketing team, thanks to our control room team. Please keep on logged on to NTV. The log in is, Beat On is coming on next. God bless, and thanks for keeping on NTV.